Good morning, everyone, and welcome. My name's Sophie Scott, and thank you so much for being here. I'm going to be your host this morning. For those of you I haven't met, I used to be the medical reporter for the ABC, so I used to do lots of stories here at the Florey with the amazing research that's done. I'm an adjunct associate professor at the University of Notre Dame in the medical school, and I'm a speaker now on the science of wellbeing and communication. Thank you for giving up your important time to be here today. And the fact that you've made time to come to this event says something about you. It shows that you care about your patients and the people that you look after. I know what it's like to have a chronic pain condition, and so I know when you have chronic pain that you'll do almost anything to get over that pain or to help manage it better. And so today we're going to hear something very new and different about managing pain, something you might not have considered, and that's the issue of sleep and pain. And a new initiative that's empowering people and physiotherapists to work with chronic pain patients and sleep physicians to improve chronic pain. And you're going to get to see this new mode of action, this model of care, and hear from patients who've actually benefited from this model of care. We're going to have a panel discussion, and so we want your questions as well. So please be thinking about any questions that you have for our experts. And to get things underway, I'm going to introduce our first speaker. He's a physiotherapist. He's got a master's degree in physiotherapy, and he moved from Scotland, which we're very glad about. Please welcome Peter Allen. Give him a big round of applause. Thank you so much, Peter.
Thanks, Sophie. Oh, my mic is on. You might hear from the accent, I studied in Scotland, but I'm from Ireland. Yeah, thank you all for being here today. I think what would be useful to understand is why we got involved in this in the first place. So I've known Professor Tony Goldschlager, who's here today, for the last 8 or so years, and I've worked in his practice seeing a lot of chronic pain patients. About 2 years ago, Tony approached me and said, as a physiotherapist, am I dealing with people with any sleep issues? And of course I am. It's something that we see on a regular basis, people with sleep disturbance. So Tony started to see this as being an issue amongst his clientele as well. So started to look into the research around sleep and pain. And if physiotherapists were able to have an intervention that could improve people's sleep, could it have a strong impact on their pain? As a physiotherapist, the current clinical guidelines that I follow for treating lower back pain are very much focused on alternatives to drugs and invasive therapies. Because as we all know, strong medications like opioids can have a significant negative impact on people's health. These current guidelines are evidence-based, they're holistic, they focus on advice and education, structured exercise programs, physical and psychological multidisciplinary interventions that can really assist people with pain. However, the guidelines that we follow really don't give much advice around the area of sleep. All they say really is that physiotherapists should provide advice on healthy sleep habits. That's about the only advice it gives. Working with people with pain and seeing positive outcomes is really the most enjoyable part of working in healthcare. I think that's pretty much what everyone in healthcare would say. What can be really, I suppose, challenging and frustrating is when people who have persistent pain continue to have some level of residual pain that, despite your best efforts, they're not improving. So when Tony approached me with a holistic, evidence-based approach that has research behind it that shows if you can get people sleeping better, their pain can improve, I was certainly very interested in exploring it further. So for us, the challenge over the last few years has been coming up with a framework that physiotherapists can use, like guidelines that could be implemented that are practical, that a physiotherapist could use every day to actually help people with pain. So we've got a short video now that's going to describe some of our journey over the last couple of years, and then we'll have a bit more of a discussion up here. Hi, I'm Peter Allen, physiotherapist. Thanks for coming to this presentation. As we'll discuss today, for the past 2 years, I've been working with Professor Tony Goldschlager, neurosurgeon, Professor Scott Heightened, neuroscientist, Dr. Harshan J. Kumar, sleep physician, and others to develop an evidence-based ancillary model of care that physiotherapists can use to consider improving sleep to improve pain for our chronic pain patients. We decided to focus on 2 key interventions. The first intervention was to screen for and treat concurrent sleep disorders.
Hi, my name's Claire. My physiotherapist is doing a physiotherapy trial. Generally, I'm sort of adapting my life to work around my lower back pain.
I think it's really important in any discussion of pain that we talk about sleep.
So if a person has chronic pain, there's a very clear bidirectional relationship between sleep and their pain, and it goes in both ways.
And sleep, as something to focus on to improve pain, can have a profound impact.
The evidence shows that patients with chronic pain are very likely to have a concurrent sleep disorder, such as insomnia and/or obstructive sleep apnea. And that when you treat sleep disorders in these patients, that quite independently of treating the site of the pain, treating the sleep disorder could in itself cause a significant reduction in pain.
One example was a study by Khalid et al. In sleep in 2011. So they did this study of people who have got obstructive sleep apnea and also chronic pain. And then they gave them CPAP therapy, and of course the OSA was improved very substantially. And they did this for a period of 6 months, and then they took away the CPAP. A really good addition to this study is that they also looked at the experience of pain during this period of time. And what they showed was that people who have got obstructive sleep apnea have got a very low tolerance for pain. Then they get treated for OSA, their sleep dramatically improves, and then all of a sudden, their tolerance of pain increases. Their experience of pain was less. And that just didn't happen initially. That was sustained, and it actually increased over a period of time. But you know what? The minute they stopped taking CPAP treatment, their pain tolerance worsened. Their experience of pain was worse. And so I think that was such a elegant example of how when you improve sleep quality, you actually reduce the experience of pain.
Physiotherapists like myself are not trained in taking sleep histories or screening for sleep disorders. So the first part of our intervention was to provide training and support to physiotherapists in order to be able to do this. I'm sorry to interrupt, but we're going to have to get started. We're on a pretty tight schedule this weekend. I'm going to stand here because they're actually recording, so I'm going to get everyone to just shuffle maybe over this way. Thank you. So thanks so much for your time this weekend. We really do feel it'll be incredibly valuable. We feel that you'll get a really good understanding about sleep and pain and how that knowledge will hopefully assist your clients in their long-term health outcomes.
Thanks everyone for coming. We've had a few of these talks now, and the questions that we get from physios are so insightful. Like, it's just a completely different world to what we experience in clinical sleep medicine. So it's really great, and feel free just to keep jumping in when I'm presenting today, and we'll try and make it as relevant as possible to what you're actually experiencing out there in the community. Just want to introduce what we've put together, which is the Physio Healthy Sleep Triage. So the Healthy Sleep Triage has been created to allow physios to quickly ascertain who needs a further assessment of their sleep for a possible disorder and who clearly has no issue with their sleep. How do we actually allow you to focus in and screen for a sleep disorder without it taking up the entire consult? Because that's my job. We run consults of 15 to 30 minutes purely on sleep. Obviously, you've got a lot more to get through in that amount of time. We're trying to ascertain whether the person identifies an issue with their sleep, whether or not pain is affecting their sleep, and then if they have any clear features of an underlying sleep disorder, such as sleep apnea by them snoring overnight, or whether they have issues with insomnia, such as waking up through the night and having difficulty getting to sleep, or having difficulty getting to sleep at the start of the night.
Beyond training in the Healthy Sleep Triage, physiotherapists were also given at-home sleep devices to give to their patients. These studies recorded information about the patient's sleep overnight, which could then be accessed by a sleep scientist and reported on by a sleep physician to consider whether the patient needed further investigation or treatment of an underlying sleep disorder for the purposes of seeing if it can reduce their pain.
Hi, I'm Wayne Johnston. I'm an ex-professional footballer from the Carlton Football Club. I played throughout the 70s, 80s and start of the 90s. Yes, I've had about 30 operations due to that process of playing football. And some of those have been with my spine, with some really nasty operations there. But I'm now looking forward to a good life after football. With the bed I'm in at the moment, and this is not digressing, but I've got 4 pillows in the bed, and sometimes when I wake up, they're all over the place. One's down near my foot. I think I must have had a fight in bed with them or something. I don't know. It's quite unique. That's when I've had a bad night with my back. Now, I look back on those nights and I go, what did I do during the day? And I still couldn't put a finger on it.
Though there is research that shows how a patient sleeps on a bed is important, physiotherapists currently have no system to be able to prescribe the support a patient needs based on their unique musculoskeletal concerns. Basically, they have no way of knowing how the patient is supported when they sleep at night, nor do they have any control over adjusting it. And so, when you look at what these patients have been lying on, when you look at the posture that the body is in, when they're lying on these beds, what's happening to their lower backs, their shoulders, their necks, it really is completely random and quite eye-opening. And so it's common for physiotherapists to have patients who have had chronic pain for years, who have had multiple interventions, been on prescription painkillers, been through the works, but no one knows what they're sleeping on, and no one has ever had any control over their bed. That's why the second intervention we pursued was giving the physiotherapists reliable control over the patient's sleep support at night. Building on research performed elsewhere, we designed a fully adjustable, unique bed system with the help of engineers that allows a physiotherapist to be able to visually assess a patient's posture in bed using a video reference monitor. The physiotherapist adjusts the body's posture in 10 body zones on the mattress, each of which can be calibrated in 10 degrees of firmness on a specially designed fitting system that is housed in the physiotherapist rooms. After fitting the body on the bed, the head and neck support are also fitted using an adjustable pillow system. The physiotherapist can then document the prescribed bed and pillow on script, which is then used to set up the exact bed in the patient's house. As the mattress is placed on a steel reference frame, both on the fitting system and on the bed provided in the patient's home, the bed setup at home exactly matches the bed prescribed in the physiotherapist's office. The physiotherapist can also, in the future, make adjustments by simply refitting the patient and providing the replacement firmness pads to the patient. The model of care with these two interventions we have prototyped is completely novel. This is the first time that we are aware that physiotherapists have been trained to screen their patients with pain for sleep disorders and refer them for treatment. And this is the first time we are aware that a physiotherapist has been able to have precise control over the sleep posture and support a patient has in their bed at home. Undertaking this feasibility study was a huge endeavour. In terms of the results, the feasibility study gave us the opportunity to run into a lot of hurdles and fix them one by one as we went. And in the end, physiotherapists have been very happy with their model's design and have found it practical to implement in their clinics. Thanks again for coming to the presentation. Let's now take some of your questions.
So that was just a little introduction to give you a bit of an idea of what we're going to be talking about in this session. I'll just briefly, you met some of the panellists in the video, but let me just give you a brief introduction. Professor Tony Goldschlager is a neurosurgeon with extensive training in management of brain and pituitary tumours. He is the head of spine surgery and endoscopic skull-based surgery at the Department of Neurosurgery at Monash Health. Welcome, Tony.
Thank you.
Professor Scott Heightened is a neuroscientist here at the Florey, and he's a professor of neuroscience at Melbourne Uni. Welcome, Scott. Sleep physician from Monash, Dr. Harsh Jayakumar. Welcome, Harsh. And welcome back, Peter Allen. Give them all a big round of applause. Don't forget, at the end of the session today, you will have a chance to ask questions, so please be thinking about the questions that you have for our awesome panellists. But Tony, I want to start with you. This was your brainchild, and you started this and brought this project together. What initially inspired you to be thinking about sleep as the missing link when it comes to pain management?
Thank you. Thanks for coming, everybody. It was a bit of a journey. Like a number of years ago, I realised that there's a big link between sleep and pain. Like as neurosurgeons, we see patients with pain every day, like whether they're waiting for surgery or they're post-op recovering, or they have non-specific back pain and they don't need surgery. And people who were in pain often had problems sleeping and vice versa. So a few years ago, I tried to collaborate with a Japanese company, a Japanese group, to try and make a smart mattress bed system but we didn't receive funding. And then Peter joined my practice, and we were speaking a lot about sleep and pain. And then serendipitously, my resident from the Alfred many years ago, Pratik, was working with sleeping duck. And we sort of like discussed it, and he said, maybe we should meet the engineers, and we got together, and this project sort of unfolded. And really, we realised that if someone who's got pain, they're doing all the right things. They do their core strengthening program. They go to the physiotherapist. They take the anti-inflammatories. They have their ergonomic desk, the standing desk, and their ergonomic setup at work. And then they go to bed and lie in flexion when they've got discogenic pain. It makes no sense. So we thought there was a big gap that needed to be filled.
Amazing, excellent. I might just move on to Scott. Thank you, Tony. But we heard a bit in the video, but I might just get you to expand. Why would helping treating sleep disorders, why would that help you manage pain?
Sure. Well, there's the research clearly demonstrates that there is this link between poor sleep and chronic pain, with worsening pain, worsening sleep, and worsening sleep, worsening pain. So it's a vicious circle. And when considering sleep and pain, or when considering pain particularly, there's nociceptive and nociplastic pain. And so this physiotherapist would well know these types of paradigms.
And can I just check with the audience, hands up who's across those two different types of pain, or if we're not, we might just get you to explain what they both are. So we've got a few. Do you mind just taking us through, I'll just get you to back up slightly and just take us through those two types of pain, just so that the audience can be really clear on how this can help both types.
So when we're talking about nociceptive pain, we're talking about the pain that is related to an injury. And so this
is more your acute pain.
Yeah,
something happens and you have an
You've
injury.
got a local inflammation response, and this inflammation that is contributing to the direct experience of pain. And if we're not well supported, particularly at night, we don't have good orthopedic support during bed, in our bed. This can cause an amplification of our pain. We want to be well supported in a firm foundation, so that we're not contributing to that injury over a period of time. If you've got it in a bad posture at night time, then that's going to worsen the experience of pain during that quite long period of time that we sleep, around about 8 hours or so. But then having poor sleep can lead to a secondary amplification of the nociplastic pain. So this is the pain pathways that control and govern our experience of pain. So under experience of chronic pain, we have an amplification of our pain signals. So even smaller signals of pain actually we experience even greater. And what we do know is that having poor sleep causes a worsening of these pain signals. And I know everybody here could testify that if you've had a bad night's sleep, everything just seems that you have more irritation. And it's true that when we have poor sleep, we've got poor mood, we've got more irritation even towards small things. But also this causes, during sleep is a very restorative time, and this reduces inflammation within our body. And so if we're not getting deep restorative sleep, then we've got more inflammation and then more underlying pain signals within our body.
And before we move on to Hush, I might just, Scott, get you to share with the audience that really interesting comparison, the study where they looked at, for chronic pain patients, they looked at doing cognitive behaviour therapy for insomnia, and then just cognitive behaviour therapy on its own, and what was more effective for pain.
So you might be referring to a study by McRae et al. That has helped to guide our work here. They published in Sleep in 2019, taking people who had chronic pain and chronic insomnia, and then did an intervention of chronic behavioural therapy for insomnia and chronic behavioural therapy for sleep. And both of these demonstrated efficacy. Both of them worked. But what was really interesting was that people who had the treatment for insomnia, actually their improvement of pain was more long-lasting. So both worked. Improving sleep improved the experience of pain to the same degree as if they had a treatment directed for pain, but treating sleep led to more long-lasting benefits.
Yeah, which is really, really fascinating. So I might move on to Harsh. So as a sleep specialist, is pain something that sleep physicians would normally be talking to their patients about?
So I think the short answer is no. So throughout my entire training in sleep medicine, I don't think we touched on pain at all. And it really only came out to the fore working with the team here about the very clear link between sleep disorders worsening pain, as Scott has very eloquently put in the last question. So we obviously will discuss patients who subjectively report pain as a contributor to their sleep issues, and when they bring that to the fore at the start of our consult, that is obviously something that we look to work on amongst all the other issues, knowing that it contributes, but we never look the other way. I wasn't ever asking my patients, do you have chronic pain, and do you think that pain was actually impacting upon your sleep? And then once we delve into that, then we go into, is that causing issues like insomnia? Is that driving other sleep disorders, such as obstructive sleep apnea, such as restless leg syndrome? And when we started looking at the evidence, it was extremely clear that yes, patients with chronic pain have a much higher risk of those conditions, but likewise, when we treat those conditions, suddenly the sleep improves, and as Scott has very clearly pointed out the science behind it, immediately their pain starts to get better as well.
And yeah, I was going to ask you about that. So is that why it's so important to identify whether a patient does have the underlying sleep disorder, because that could be crucial in helping reduce the pain?
Yeah, and I think that touches on what Peter said, that we're really looking for alternative methods to treat people's pain outside of medications. Medications is our break glass in case of emergency when we talk about chronic pain. In acute pain, they have a role. In chronic pain, you really want to break that cycle of medications, increase in doses, more tablets. And once we started identifying that these patients have sleep disorders at a higher proportion, we found evidence that we treat these sleep disorders, suddenly the pain gets easier. Well, we know that cumulative effect of all those interventions can certainly mean less medications, but also better quality of life.
Okay, excellent. So Peter, on to you, and thanks for the video. It was a great explanation. But I'm just keen, the audience might like to know, what's it been like integrating sleep science into your work as a physiotherapist?
Well, when Tony initially broached the idea, I thought, well, why haven't we done this before? It makes absolute sense. We focus on advice and education around diet, around exercise, but I suppose that link was never really explained in terms of how big an intervention sleep could be in terms of reducing people's pain. Some physiotherapists certainly do discuss sleep, but it's not discussed in university at a high level. There's not many courses that I'm aware of at all that have any focus on sleep, professional development courses. So for me, it was really eye-opening, and it's been fantastic. Like the feasibility trial that we conducted, where a lot of patients of mine, some are here today, who I'd seen for some of them multiple years, and by just asking them about their beds, which I felt a bit naive when I said, what are you sleeping on? And then they're sleeping on 15-year-old beds. Well, of course, that's going to make an issue. So just even asking them about what they're sleeping on, what position they lie in, do they have a sleep disorder? Like I've had patients, I hope not through my own being boring, but they'd fall asleep in a session, and I just kind of laugh it off, and I just think, and I'm like elbowing their back, and they're telling me that, and they're snoring, and I never once said, like, oh, you clearly have a sleep issue.
Do you have daytime sleepiness?
Yeah, exactly, and I never put two and two together. So for me, it's just added to my care completely. Like everyone now, when I come to nighttime symptoms, usually I'd say, do you have a sore shoulder in bed? And they'd kind of say, yeah, and then I'd say, well, maybe don't lie in it. Now I can actually say, do you have a sleep disorder? Do you have sleepiness? Do you have pain in bed? I can really delve into it, and it doesn't take away from my clinical care. I can just question it, and then I can refer on quickly when I need to.
We have a bed here.
Yep.
Are you able to show us with a patient how you can actually fit the bed to the individual patient? And I think we have Wayne. Do we have Wayne in the audience?
Yeah.
Wayne, come on up, and Harsh. We're going to actually take you through and show the audience, just so you can get a really great understanding of what actually happens. So let's start. We'll start with the Wayne. Come on up. Give Wayne a round of applause, everyone. Good on you, Wayne. Thank you for being here. So let's start with these sleep devices. Harsh, what are the sleep devices we've got here?
Yeah, so part of what we've been trying to put together through this work is how do we allow physios to quickly and effectively screen for a sleep disorder when dealing with chronic pain? We don't want that to be the focus of their consult, although it is a very vital point, as we've just discussed today. how do we make sure that we're getting the crux of the issue out and then being able to push them on down a pathway that allows them to handball that responsibility to the people with that expertise in that area, myself as GPs with a special interest in sleep medicine, and that's where some of these devices that really investigate sleep in more detail. So Wayne, as part of our feasibility trial, used what was called a SOMFIT that you would have seen in that video, which was a little probe on people's head, and it really provides quite a lot of data around sleep medicine. It's not the fully fledged sleep study that we would do in a hospital lab or in someone's home, but it gives us a really good idea of what is happening when you're sleeping, and certainly can pick up a number of sleep issues. We do have level 3, which is the SOMFIT, or a level 4 device that I've got here. This is a very small, very simple device, very easy for physios to fit to their patients, let them take it home, get some very accurate data on what we're trying to investigate, things like their oxygen trace, their movements in bed, are they having a sleep disorder, and should we be looking to investigate that further? And so that is all a person would put on, put a wristband on their watch, or on their wrist like a watch.
A bit like a sort of, Apple Watch fitness tracker that so many of us already use for everything else. In fact, mine's been telling me to stand up while we've been sitting down.
And just a little finger probe that plugs in, and that's all you would wear to sleep at night. But because we have enough data on there and the ability to use that on multiple nights, so we get actually a much more accurate data than a single night study, which doesn't really reflect reality when you're wearing 100 wires to sleep at night.
And then, Peter, can you just show us with Wayne, so how would you actually just fit the bed with Wayne to the bed?
So I have fitted Wayne. We'll hear a little bit about, I guess, Wayne's experience at some point. But when it comes to the bed itself, it's a system. It's not just a mattress, because what's important is what they lie on, what the mattress is placed on is also just as important. So solid steel base, meaning that it's a reference pad. If they come for a fitting with me and then they go home and they place it on an uneven surface, well, it's going to impact it. The mattress itself, the main focus as a physio I'm looking at is these 10 zones. So these zones have different levels of firmness. So we got medium level of firmness here, but I can then correlate that with different sections of the body. So if I want a firm lumbar support, so in the lower back where he needs support, but you need to offload the shoulder, then I'll be able to adapt and have firm and soft. And then there's a pillow as well that's height adjustable. It comes in different layers that I can just adapt as well and change. I guess with regards to Wayne, so I have already fitted Wayne, so I kind of have a bit of an experience there. But the first thing I do as a physio is, for the opening 30 minutes, I'm conducting an assessment. I'm talking to Wayne about his sleep health. I'm trying to consider, does he actually have signs of sleep apnea? I might ask him some outcome measures, such as the Epworth Sleepiness Score or the stop bang. If anything is maybe indicating signs of that, I'll provide him with the watch, and I'll say, go home and sleep with that, and we'll figure it out a little bit more. On top of that, I'm conducting a musculoskeletal assessment. If Wayne says I have lateral hip issues, I have a shoulder issue, I have back pain, I'm trying to think, how do I adjust the bed to take account of all those issues? As well as I'm considering his body size, his shape. With Wayne, I might get you just to turn and face this way, Wayne. So Wayne has a little bit of a list. So because of maybe a slight leg length difference, because Wayne has had an ankle fusion, has had multiple lumbar surgeries, there's a little bit of a list to the left, a little bit of a lean to the left. And with Wayne being a right side sleeper, which I'll have him on the bed in a moment, I'm not trying to get him to have a perfectly straight line, because that would be counterintuitive to his whole body. His body would be fighting against it overnight, because this is his natural standing posture now. So as he lies down, I'm basically trying to match that. I'm trying to probably firm up through that area here to keep that level in the position it's in, while trying to soften through here to replicate that line of the spine. So Wayne, I might just quickly get you on the bed. So what you're going to do is you're going to put your pillow where you would typically put it. You're going to put it down that end.
On this end, or?
Yeah, well, you sleep on the right side, Wayne, don't you?
I can sleep either side, but the right side mainly, yes.
Let's go for the right side now.
Okay. You want me?
Shoes are good. Shoes are good. Don't worry about it.
Now Wayne has his best seat in the house now.
Yeah, exactly.
I didn't recognise before. I didn't think this would ever work with this pillow, but
Yeah, no.
this is my pillow.
Because people are in love with like contours and thick pillows, but when physios fit people with pillows in their rooms, we usually do it on a plinth, and it really doesn't replicate what they'll be lying on at home. So I don't know, you may be able to observe here, as I'm going through the process, which is a subsequent 30 minutes with Wayne, I'm talking to him about the landmarks on the body and how I'm seeing. So in standing, he does have a little bit of a left list. So we're actually seeing a little bit of that now, which isn't the worst thing, but you can clearly see the indentation on the bed here. That's where the weight is going through, the abdomen and the pelvis. So I'd obviously have Wayne with his shirt off when I was doing it in the room, and I'm trying to match up what it looks like in standing while also considering his musculoskeletal issues. So with Wayne, like, it's actually not terribly bad at the moment, but what I'd do is I'd firm up a little bit more through here, potentially soften a tiny bit here, and maybe make an adjustment to the pillow, because his head, once I make changes, might change its position on the pillow. So I'm going to just quickly play around with that just to show you how easy it is. So Wayne, if you just sit on up just a moment. I'm going to go a bit softer here, tiny bit firm here, and then 3 and 7, 3 and 6. Now, when I did do it with Wayne, I spent quite a bit of time. Obviously, I'm just giving you guys a truncated version. It's as easy as that. I'd then get Wayne back lying on the bed just to see. You're lying in the same position, Wayne, again. Again, so what I've tried to achieve here is I'm trying to even soften more in through the lumbar, because in standing he had that clear list to the left side, so softening there. I'd be looking at his spine. I've firmed up a fraction through that area to get him up into more of a lateral lean up around the thoracic. And his head position being a little bit high at the moment, I'd make a quick adjustment to the pillow, so I'd drop down the height of the pillow a fraction. I'm not going to do it now for the purpose of time, but everyone's going to be individualized. Everyone has their own unique position that they lie in bed, what kind of complaints that they have, and I'm just going to adapt the bed based on what I see. The beauty of this is as well, if I don't get it right the first time, they'll go home and sleep in it, and to be honest, we get it right most of the time. The zones can be adapted. So when they go home and they get a fully designed bed, it's going to be adaptable. I can make changes. So let's say Wayne, unfortunately, was to have another injury and that led to a change in his posture, or he had a shoulder issue. I can make adaptations over the course of 10 years. So yeah, I think that's probably...
Amazing. So give them a round of applause. Well, come and sit back down. We're going to let's watch another short little video now, which is going to delve a bit deeper into the research, and particularly the next phase of the research into this bed.
Let's talk a bit about the results of our feasibility trial. The research already shows that improving sleep can make a significant impact to pain. Our work was to put that in place by creating a practical model of care for physiotherapy practice. That work has been successful, and we plan to expand it into a number of pilot clinics. Quantitative research is needed to examine the outcomes that can be achieved by incorporating this model of care by physiotherapy clinics. And we are currently coming together to collaborate on a randomized control trial. However, we are pleased to report that the 6 patients with chronic pain that have participated in our program so far have all had excellent results, above and beyond what they had achieved by standard of care physiotherapy practice alone.
So living with pain, it's like living with a shadow that follows you everywhere. We were travelling at full speed, high speed, along a country road, and a car came out in front of us. I ended up with sacroiliac joint dysfunction and lower back and neck pain. And then age kicks in and degeneration happens, so you're sort of always chasing your tail. Of that sent me on a search for a physiotherapist, yoga, meditation. 2 years ago I had a neurostimulator implanted in my back. Recently I just had a total knee replacement. You clutch at anything you can to return your back and your lifestyle to its reset position or its original, active ways. I would love to be able to just take a Panadol and have it fix a pain. That blows my mind too, that people can take a Panadol and it fixes it. My physiotherapist is integral to managing my ongoing chronic pain. But recently, my physiotherapist told me they were participating in a new program where they could work on my sleep. I actually had a lot of pain in bed. I was sleeping with up to 7 pillows. And it was the first time that had happened, that people had asked me about my sleep. We'd discussed, what my bed is like, how my sleep is. Do I wake up refreshed? Do I wake up in more pain? So around those discussions, realised that my sleep wasn't great. My physiotherapist performed an at-home sleep test to look for sleep disorders. So fitting me for my customised mattress, You're lying on your side, you're watching the screen, and if you imagine there's sort of a line from the base of your head to the tip of your tailbone. Pain that I was getting in my hip or my shoulder tip, you know, and adjusting the mattress in its firmness in those places to make room for my shoulder, to make room for my hip, to support me in my mid-spine. You can see why your shoulder isn't comfortable in that position. You can see why your hip isn't comfortable in that position. You can see why your mid-spine is not sitting nicely and comfortable, so it's any wonder that you're sort of waking up in discomfort because, you know, your body's working against it all the time. I noticed the improvements with my pain literally after the first night. It was great. To wake up in the morning without that deep pain that you have in your shoulders or your hips, lower back. It's really quite refreshing, and to wake up refreshed and to not wake up during the night because you're not in pain. So that is just such a benefit. So my activity level in terms of on waking, I don't have to wait so long for my body to loosen up. So my family and friends have noticed that, you know, I'm more enthusiastic about, you know, taking on some of those activities because I'd sort of backed off a lot of those things because of pain in achieving those activities. You know, sad state of affairs at my house is a bit tidier and cleaner because it doesn't hurt to do those things. I can walk up to the shops, I have a brand new baby grandson, I can pick him up, hold him and nurse him without any effects, and that's just from being pain-free.
Claire's results from the programme are not isolated. Another participant, Wayne Johnston, experienced significant reductions in neck and back stiffness. And I think we've got the one here.
Oh, God, that's another world.
Excellent. So I think that's the pillow that we're going to go over.
Yep.
He's now able to walk 15 kilometres at a stretch and has returned to full-time work with renewed energy. Tim, a participant with long-standing, debilitating lower back pain at night from discogenic back pain, experienced complete resolution of his pain, while his partner, Nish, also experienced a significant improvement in her neck pain and cervicogenic headaches. In fact, all of the patients involved in the programme experienced a reduction in chronic pain, showing this model of care has vast potential. We hope that these results will be replicated in a randomised control trial. Physiotherapists now have a new holistic tool in the management of chronic pain, and we hope this will make a real difference to their patients.
Very interesting. So I'd like to welcome, we've got a new panellist, Dr. Hannah Vickers. She's a Chronic Pain Australia ambassador and a junior doctor practicing in Melbourne, and she has lived with chronic pain herself for about 6 years, and she had investigations and surgery and nothing could really help, and she actually worked with a pain coach overseas, and the pain coach was really, as she was just telling me earlier, very helpful in helping her expand her comfort zone, and she's been able to do things like go back to running, which she never thought she'd be able to do. And so we're really grateful to have Dr. Hannah Vickers here. So Hannah, what are your thoughts, both as a pain patient but also as a medical expert, about including sleep in pain management?
Well, as been mentioned before, sleep is often neglected in terms of a factor towards pain. And I went from many doctors to doctors in terms of thinking about what might be causing my pain, what could be done about it, and no one asked me about my sleep until I came to see that chronic pain coach that I was speaking to you about earlier. And everyone knows that pain is just not one thing standalone. It needs to be managed holistically, thinking about the person as a whole and personalising towards them, which this much does so well. And then in terms of kind of as a doctor, I'm working in the emergency department at the moment. We get a lot of patients come in with chronic pain, just desperate for some sort of treatment. And as a doctor as well, it's quite difficult because you want to do what you can to help them, but beyond kind of giving analgesia for that particular acute episode, there's not that much to turn towards. So I think it's exciting from both point of views. I've been the doctor, been the patient in that situation, to have something that can be prescribed and tailored towards you to help that kind of long-term goal.
Amazing, thank you. And Scott, I might just get you to talk to the audience about what's next, particularly when it comes to the research into this model of care.
Sure. So I think what you've seen from our feasibility study is a great potential for what we can do in terms of seeing improvements. But this is not rigorously well-controlled clinical trials. This is a feasibility study that we need to certainly develop our evidence base more of. We're drawing on a large body of literature that does connect pain with sleep, but now we need to see if these interventions can really lead to substantial improvements to patients' sleep and then therefore their pain. So the improvements of the interventions of addressing sleep apnea and also modifying their bed to improve their posture during sleep, we're going to test in a randomised controlled trial to see if this leads to the improvements that we hope, and in a way which is going to stand to rigorous evidence that we all need when practising medicine.
And so in this randomised controlled trial, you'll look at things like pain levels, but also other things like inflammatory markers as well.
Yeah, we're going to be looking, obviously we want to look from a holistic sense. We want to see, do the patients improve their sleep? Do their markers of inflammation go down? Does their subjective experience of pain decrease? Does their objective measures of sleep improve? So we'll collect a range of measures from these participants to see if they've improved.
And what do you think this larger trial might tell us about the potential of this intervention in terms of whether it can be scaled to a broader population?
Sure. This is. I think we need to develop this evidence, and we're doing this work in this year, and we'll continue to collect this evidence because not only does it tell us the importance of these particular interventions that we're developing and rolling out, but also adds to the broader literature-based connecting sleep and pain, which we want to contribute to. Everything that we do, I think, has got to be grounded in evidence, and that's what we're setting out to do now to demonstrate that if this improves patients or not.
Fantastic. So we're going to invite Wayne to come up and Claire, if we've got Claire in the audience as well. Give them a round of applause. Come on up to the end. And while they're coming up, I just wanted to ask Tony, what was this was your brainchild in a lot of ways. How surprised were you that you had such great findings from this initial first study? What was your response to the first when you found out how well it had gone?
I was actually quite amazed. Like Wayne and Claire have just come of their own accord because they really have benefited from it. I see Claire at Keyser, where we both go, so I can't hide from her. And it's been been very successful.
Amazing. So we've got about just less than 15 minutes left. So now is the chance for you, in the audience, if you have any burning questions that you would love to ask any of our panellists, just raise your hand.
Thank you very much. Professor Fiona Dobson from physiotherapy here at the University of Melbourne. Look, I really admire your work, guys. It's really lovely to see, and it's lovely to see the immediate results for Claire and Doug before us. I'm really interested in your randomised controlled trial coming up, and in particular to the pain outcomes that you intend to use. My research is in chronic pain due to osteoarthritis, particularly hip osteoarthritis, and we find time and time again after lots of clinical trials that there's a massive placebo effect of just that contact, and that pain reduces regardless of what you do, and to a substantial degree. So I'm really interested in knowing a little bit more about what pain outcomes you plan to use. Thank you.
So who would like... Tony, do you want to answer that one?
That's a very good question. I share your experience. I did a large study with stem cells injecting patients for back pain, and the control group was normal saline, so just water, in their back versus stem cells. and everybody improved. Like at 3 months, everyone was better. And but then when you keep looking at the data, the curves diverge. By 12 months, you can start seeing the effect. So it's difficult because like the big placebo effect. So some of the outcome measures are subjective, like VAS scores and Oswestry scores and quality of life scores. But we're also going to look at quality of sleep, which is an objective measure, and also inflammatory markers, which is objective. So you get a bit more broader data.
So trying to look at it as broadly as possible so you can sort of account for that potential placebo effect for having an intervention.
I'm not sure about that.
But that's good, but thank you for that. Yeah, thank you for that
I'd love
question.
to chat after this, by the way.
Peter, did you have
I was going to say the exciting thing we've seen to maybe offset the placebo effect is that this trial was conducted in 2023, so it's a 3-month intervention. Obviously, the participants are still sleeping on that bed, and as you can see today, the outcomes are still long-lasting and withstanding. So I feel like, yeah, it is showing some strong signs that this could be longitudinal.
Yes, interesting. While we're going to the next question, did Claire or Wayne, did you have anything, burning things you wanted to say? And then just raise your hand and we'll go to the next question in a minute.
The change in my life, obviously, was with Tony and the surgery that I received back in the early 2021, yeah. And then with the ongoing physio with Pete, sorry, and it was quite a phenomenon because I was in a lot of pain prior to that. 15 years ago, right through that entire strip of my life, I was really in a hell of a mess, taking a lot of the opioids, not in a good zone mentally or physically. Just as recently as I've had the bed in my house, or my second house as well, my day actually starts when I go into the bed at night, about 9:30, 10 o'clock, and I wake up at 5:30 in the morning, getting ready to go to work. Then I go to my little gym area in my house and do my exercise for about 45 minutes, have my breakfast, get in the car, and I go to work. And however many hours I work. And I go home, and sometimes I might have a little nap on the bed when I get home if I'm early enough. But I never dreamed I'd be doing that again, ever. Not even close. And even as early as today, like today, I had to sleep in to come here, and I did a 48-minute workout. It's not a grueling one, it's just to stretch and make sure all the parts of my body are still connected together. And I got myself here, and my life has changed dramatically, and even my sons will tell you that I have a smile on my dial nearly every day now. I'm not fighting any demons from within my body. I'm not fighting any external demons either, because I don't hang around bad vibes, and it has changed my life, sincerely it has. And if anybody had told me that little pillow was going to be a help to me, I would have just laughed in your life. But also the thing is, one thing that's good is I can go into the bed, I can lie flat on my back if I like for 10 minutes. Sometimes I do that just to put my head back on the pillow and just meditate a little bit about what happened during the day and what I might do tomorrow. Then I usually, as Pete says, roll over to the right side, and I usually get a very, very good sleep. Obviously, there's times when you don't. Just recently, if I can digress a little bit, I was just up the country with my friends, just having a long weekend up there with one of my sons, and after I had 3 days without the bed, I woke up like Quasimodo on the way back home to getting back to Melbourne. But thank goodness I got to bed last night nice and early, and the bells are ringing. I'm as good as gold. So it has been a change, but it's only just a start for me. I really want to get a lot better than what I am right now. I want to be double that in the next year or so.
Give Wayne a round of applause. Good on you for doing that. Thank you for sharing. We'll go to Claire in 1 second. We'll just go to one question, then we'll go to you next, Claire. Yeah.
Hello, Russell Howcroft here, advertising guy, media guy. I think the Dominator might have just answered my question. I'm wondering who builds this thing. Yeah, what brand, what manufacturer?
Tony, one of his residents, worked with Sleeping Doc. He was one of the owners. So we got together as an MDT with medical people, and we created SD Laboratories, which is the medical division of that company. So it's a separate entity to Sleeping Doc, but they're the ones who manufacture it.
Claire, do you want to give us a little bit, just briefly talk about the impact it's had on your life? I mean, we heard a bit in the video, but it's always great to hear the lived experience.
I guess just from hearing everybody talk today and just recapping, discussions and trials that we've done, it's just another thing in my toolkit for chronic pain. And if you can get that restful sleep, that solid sleep, makes all the difference. Even, from having a disturbed sleep to waking up rested, you can then go on to do your supportive work in terms of physiotherapy exercises, strength training, or pool work, or just life. You can do all those things if you're rested. If you're not rested, you're up against it to start with, and your body fights against that, I think.
Fantastic. Thank you for sharing that. Just raise your hand if we've got another question here. We've got 2 questions. Oh, we've got lots of questions. Yeah, we'll try to get through all of them. Yep.
Thanks. Professor Amy Jordan, I'm in psychological sciences, but I'm a sleep researcher. I feel like I'm going to counter the physio's questions with the sleep questions. So
okay.
A simple one first. Have you considered putting the SOMFIT on your 6 feasibility participants, because you've got the baseline data, so that would be very interesting to see. But then for the RCT, I'm interested in what your objective sleep quality, what metrics you're going to be looking at. And then one final one, if I can, for afterwards, is how you're going to placebo control, because as you've mentioned, that's very important.
Sure. So we did use a SOMFIT for the 6.
Can you just explain what that is for the audience who might not know?
So it's a device, an EEG device. You attach the head. You've sort of seen that in the video. So this was attached. We've got data for that. And Harsh, did you analyse the data for that?
Yeah.
You did. Do you want to comment on any of that?
So look, it's a level 3 device. It's not a fully fledged sleep study that we would do in clinical practice typically, although the evidence isn't growing that these sorts of devices provide excellent clinical utility, especially the ability to do it on multi-nights. And I think that relates to your question of can we see the improvement in the sleep architecture as much as in the chronic pain scores. And so yes, we did do that as part of our feasibility trial. Yeah.
The real use there was that it picked up on sleep disorders that weren't previously diagnosed. So we did stop bang and ESS pre-test, but the actual EEG then confirmed sleep apnea, particularly in supine, during REM sleep, and then also insomnia in 2 individuals as well. We could see that their total sleep time and their sleep efficiency was poor. So yeah, it was useful for that.
Okay, and keep going, Scott. Yep.
And going forward into the clinical trial, we'll have got a device that sits underneath the mattress. It's a ballistocardiography device that we're going to be using to monitor sleep. And also, I think this is yet to be confirmed, but we'll use another device, the one you just mentioned, to monitor sleep.
Yeah. Looking at a level 3, level 4 level device to get night-to-night studies.
And at the same time, taking people's experience of sleep. Of course, that's subjective, but part of sleep is subjective as well. So we need to...
how you feel, how you sleep, as well as looking at the data of how you actually did sleep.
But also would love to talk to you about some of your thoughts, as if we can incorporate some of that.
And so the researchers and everyone from the panel will be around after this. So if we don't get everything, or you want to go a bit deeper with anybody, they'll all be around to answer questions. Yep.
Hi, I'm Kath Johnson. I'm a freelance journalist, and my question's a really practical one. How much would a bed like that set the patient back? Will it only be physios that can prescribe a bed like this? And can you even just get significant improvement from addressing the sleep disorders if they have one, and maybe just getting a new mattress?
Yeah, good question.
Peter,
very practical question.
Did you want to, there's a few there. So first of all, let's talk about cost. Yep.
Yeah. So the bed comes in 3 sizes: king, single, queen, and king. The baseline rate for the king single is 5,200. For a king, it goes up to 7,000. That's the bed-based mattress and pillow. The person has a 100-night pain trial. So if they go through the process, they get fitted, alterations are made, and it's still not appropriate to that person, they get their money back. So it's at no risk to that person. So the physiotherapist certainly doesn't want to put their name to something that's not helping the person. So there's no risk for the physio or the client. It's available now in up to 30 clinics across Australia, and by the end of the year, we'll have over 100 clinics offering this service. Our plan is for a large proportion of Australian physiotherapists to be able to offer at least good quality sleep advice, education, identify sleep issues, and then, as I say, in up to at least 100 clinics being able to offer a bed fitting. What was the rest of the question?
Is it enough to just treat the sleep problem and then say
So like if a physio can just identify sleep issues, no one else is identifying these issues. As Claire said, she's never been questioned on sleep or her bed, for example. If just physios were talking about sleep apnea and we're able to pick up and see the signs of, oh, you're not refreshed in the morning, you might want to get that tested, like, that's going to have a massive impact. Like, so the bed is an adjunct, it's going to be something extra, and a lot of people will require this, but a lot of people might just need CPAP and a good quality supportive bed. We are also hoping that this becomes a standard model of care, that people who are availing of government resources to help support their issues, that they'll become part of this whole process, and that potentially people could purchase through their packages and things. So yeah, this is just the beginning, I suppose.
And I guess that's why it's so important that you do the randomised control trial to really show that, have that really good body of evidence to show it makes a difference.
We're evidence-based practitioners, as everything we've said today, as we want to have the evidence. The signs are very encouraging to begin with, and people can, at the moment, purchase this system. They can see their physio and do it, but when we actually have randomised control evidence, that's going to be fantastic.
Yeah. Got a question. We've got two quick questions here, and then our panellists will be here. So we do need to wrap up soon, but the experts will be here for any other questions.
No worries. Not so much a question, but a comment. I'm Kingsley Gibson, physio in Sydney. We have 2 of these Z10 beds in 2 of our clinics ready to get up and running and do more assessments. So a comment in terms of the training. Peter and Harsh are doing a Zoom 1-hour conference with us in a couple of weeks to train up our physios in terms of the questions about sleep apnea and sleep disturbances, etc. So we're more experienced in that, and we can see the value in that from what's been presented today, but also then presenting more about the concept behind the bed. And I'll probably speak for a few physios in this room. One of the worst questions you can ask as a physio is, what bed do I get and what pillow do I get? And there's never been an answer to that in the past, because you don't want to put your foot in it and suggest the wrong thing, other than say go to a bedding place and say, ask them if you can sleep overnight, and you'll get some idea. So this is now a concept that I'm personally fully supportive of, because people can trial the bed, they can play around with it, and if they're still not happy, they can give it back and get their money back. So we're very safe as practitioners to suggest this type of bed. The other thing I'd say in terms of people who haven't, in terms of this Z10, is before you go over and feel an F1, and feel an F5, and feel an F10. And you'll see the significant difference in the density of those foams and the scope that you can play around with in assessing patients and try and optimise what you can provide for them, whether it be for sleep quality, whether it be for sleep disturbances. And we've also trialled it, and Peter's been a lead in that, on some athletes, just in terms of quality of sleep and performance. And there's a couple of case studies there which probably could be expanded in that area. So thank you.
Okay, thank you. Do we have one more quick question somewhere? I saw someone else's hand up. Yes, this will be our last question. And everyone when we wrap up, which we will soon, you can all come and have a feel of the bed and the squishy bits.
This is just a comment. I am the GP. And
excellent. Well, welcome.
Yeah, so I'm a GP, and I think 2 of the most common presentations that come through our doors is pain, chronic pain, and poor sleep. And this is very encouraging because we have something in our toolkit. As Peter said, physios are the experts in chronic pain, but often when we have that patient come in and I take purely a pain history, often I don't ask about their sleep. They may say I've had poor sleep, but that link is often missed. And then the person who comes in poor sleep, I'm hyper-focused on the sleep, but often I'm not. Are you in pain? And often they are very linked. I don't have much in my toolkit. It is medication. I have a bit longer with the patient than the ED physician does. But it's very encouraging that I now know that, the ways that a physio can help, how they can assess the sleep, how they can assess their overnight pain whilst sleeping, and I think that would make a dramatic difference, not just for chronic pain and sleep, but we know that both are also linked in other chronic conditions like your diabetes, your hypertension, your obesity. The inflammatory pathway is very linked in many chronic conditions, so if we can target sleep and pain, we might actually see an improvement in many of these chronic conditions or improve quality of life for these patients.
Amazing. We're very glad to have a GP in the audience. Thank you for your comments, because GPs are the gatekeepers and the front line where people do go when you're in pain to your doctor first. So we appreciate your comments. So did you have a question? All right, so look, it's midday, or it's after midday, so we need to wrap up. Please give the panel a big, big round of applause.